Dr. Neha P. Shah, ma'am. So Dr. Neha, ma'am, is based in Mumbai, India, and she practices general ENT and radiofrequency and OSA surgeries. She has done her master's from prestigious Topiwala National Medical College in 1999 and stood first and won many awards at several locations for MS and FCPS examinations. She was amongst the pioneers of radiofrequency ablation techniques for snoring and sleep apnea. She has also gained extensive experience in the UK. She has authored a book, Clinical ENT, and did several presentations to her credit and overseas also. So many sections, including the case presentation, have been written by her. So to be to give a personal thing, we have actually read ma'am's book, The Clinical ENT, and we have passed by reading her book and reading the techniques which we want to present to the examiners. So that's why we have Dr. Neha Pisha ma'am here for a case presentation. So ma'am will be telling about how to do a case presentation in case of a carcinoma larynx patient. So after that, Dr. Zakir Hussain sir will join us and he will take the instrument section and how to deal with the instruments. So Dr. Zakir Hussain sir is also with us now. Welcome, Dr. Zakir Hussain sir. Neha ma'am, up to you, ma'am. Now you can start the presentation, ma'am.
Yes,
Thank
yes,
you so much, ma'am.
sure. Thank you. Thanks for the introduction. Thank you very much for this opportunity as well. Now, as regards this presentation, first I'll just mention few things to the students. This is solely for the students. Circumstantial is not conducive to present right now. It's solely for the students that have done this. One, I'm not a larynx person as such totally, but I've tried to compile things in a manner which may be conducive to the students as much as possible. Second, now this we are presenting assuming that this is a case of this is the patient is a case of carcinoma larynx, understanding that, and then we are presenting this. Second, third, all I'm talking regarding examinations. Third, all straight away we'll go to the schedule. Okay. Third, all greetings to the examiner have to be maintained, like good morning, good afternoon, whenever your exam is, and all what have you learned, how to present case has to be followed. The protocol as such exactly has to be followed. So now straight bang on, we'll go to the history and case presentation. Now, first, there is a protocol which needs to be followed regarding carcinoma larynx, regarding a larynx case. We have done it as a medium or a short case for MS examinations. Your case usually used to be a longer case. This year we presented a format and a pro forma which may suit all examinations probably. So now beginning with that, straight going to the history. Now first I'll tell to the student, let this be a session wherein you all are learning right now everything, just like a revision, learning and a revision straight away. Things may be repetitive, but finishing off right now, straight away. So take it as this session. Abhi exam ka sab kuch kar lena kind of, you know. So I've tried to compile it in that manner. So case presentation, carcinoma larynx. Now straight, first history. Now history, the first main few points, I could have loaded this with animations, but I haven't because that would catch the eye, but wouldn't remain static on it, you know. So this year you'll be able to read the slide for a slightly longer period of time. So history, points. So first point, change in voice. Second, dyspnea. Three, cough. Fourth, dysphagia. Five, odynophagia. Six, foreign body sensation or clearing of throat. Seven, swelling in the neck. Eight, the etiology. Tobacco, alcohol, vocal abuse or overuse, tuberculosis and syphilis. So these are the main points which you have to consider for a case of carcinoma larynx. So first point, change in voice. So change in voice, what will you ask? Details. All details regarding change in voice has to be asked to the patient. But there is a difference between change in voice and hoarseness. Ideally, if you know the definitions of each, that would be helpful to you. All of it to cover, it will be a very long presentation, but yet I'm telling you the main important points. Hoarseness can be defined as a rough, husky voice. The questions to ask for hoarseness would be onset, duration, and progress. Per se, onset, abrupt or sudden, or slowly progressive. That will give you a rough clinical idea as to how the patient is having the clinical problem within the person. In short, if the patient has, here we are again assuming the patient has already carcinoma larynx. So if the patient has carcinoma larynx tumor, how it has progressed. Suddenly there is a change in voice or a gradual change in voice. That will give you some input or idea regarding the growth of the tumor. Duration, since how long, so you will know how long the patient has been suffering with the problem. And progression, so you will know what is the stage, or just a rough idea, clinically, an idea as to where does the patient come fit into. So hoarseness, common causes also, they may ask you straight away when you mention hoarseness, some examiners may just ask you, what are the causes of hoarseness? So you should know something on, so I'll mention topics as well. Lesions of vocal cord. Hoarseness is seen in lesions of vocal cord, vocal abuse, laryngeal inflammation, mobility disorders, and malignancy. Next main clinical complaint is dyspnea. So first was change in voice, which is mainly hoarseness. Most patients present with hoarseness. Next, dyspnea. Now, a little bit on hoarseness still. Hoarseness is very common in glottic carcinomas, supraglottic as well when they approach towards the midline or even cross sometimes, and subglottic later on. So next chief complaint is second, dyspnea. Again, any chief complaint, first thing, any chief complaint, you have to take down the details as much as possible and then to the causes and rule out other factors. So dyspnea, again, the details, intermittent, continuous, how bad is the dyspnea, associated with any other sputum production, then again details on sputum production, or associated with any other pathology. Now, dyspnea common causes are obstructive pathology, there's a whole lot list, and stridor. Stridor is also one of the kind of dyspnea. Some patients may present with stridor when they have carcinoma larynx. These are late cases, usually can be. Your students may not likelihood to get such cases wherein stridor is already present, but yet sometimes can be. You are likely to be asked causes of stridor. All of it is given in detail. I mean, I wouldn't say only my book or something, but all of it is given in detail in all books. But you could refer to clinical ENT for great details of causes of stridor as well. So first complaint, change in voice or hoarseness. Second, dyspnea. Third, cough. The patient may complain of cough. You need to find out one, whether it's dry cough. Second, whether it's productive. And third, whether it's blood stained or not. All of it gives you idea regarding the pathology. Fourth complaint, dysphagia. Dysphagia is difficulty in swallowing, and next complaint, odynophagia. Odynophagia is pain during swallowing. Both these problems are common complaints in supraglottic tumors. Next, foreign body sensation in throat or constant clearing of throat. This is also a common complaint wherein mucus or sputum stuck over a growth, laryngeal carcinoma growth, and patient has constant complaint of inability to clear the throat. So constant complaint regarding that. Now, all of these complaints you need to ask onset, duration, and progress, and any other feature. I have mentioned this in the sections which are coming across. Next, any swelling in the neck. Swelling in the neck may come across if the tumor has uh, crossed the boundaries or margins of the larynx and is showing across as a growth to the exterior. Or the swelling in the neck may come across because of lymph node swelling, which is because of metastasis to the lymph nodes. So swelling on neck, two reasons, tumor or metastasis. Next, you need important in CA larynx is the etiology, history, alcohol and smoking. Need to ask in complete detail. Both of it, how many times in a day, since how many years, any other uh, any other addiction as well, and so forth. Vocal abuse. Next history you need to ask. I wouldn't say abuse for teachers as such. I would use the word overuse as such. But vocal abuse or overuse common in teachers, singers, hawkers, and so forth. If any of that has led to any problems. TB and syphilis also need to be asked. Actually, these come under differential diagnosis of carcinoma larynx. This is clinical after knowing that the person has carcinoma larynx. Tuberculosis, you'll seldom see, this all comes under examination, you'll seldom see, but it's a very, very, very important point. You'll seldom see fixation of cord, early glottic carcinoma with a spread outside the glottis, you'll see fixation of the cord. Tuberculosis, you'll see asymmetric distribution in the larynx of tuberculous laryngitis or tuberculous pathology of the larynx. And carcinoma, you will see relatively symmetrical distribution in the larynx. Tuberculosis, you'll see whole width and length of the cord is disease. And carcinoma, you won't see whole length or width of the cord disease. In tuberculosis, you might have ulcers which are undermined, while in carcinoma, you might have ulcers which are or heaped up margins, and everted edges. Syphilis is rare, and you might have ulcers which are painless, and in tuberculosis, you might have painful ulcers. So these are the gross differences between tuberculosis, syphilis, and carcinoma larynx. So now, history-wise, these are the chief complaints the patient comes in. In short, change in voice, change in speech, hoarseness, hot potato for supraglottic, dyspnea, difficulty in deglutition, pain during swallowing, hoarseness of voice, swelling in the neck, hemoptysis, cough with expectoration, sputum with blood, foreign body sensation, clearing of the throat, referred ipsilateral otalgia in supraglottic carcinoma because of the referral to the nerve, choking on swallowing food, and history of etiology, tobacco, alcohol, voice abuse, overuse, tuberculosis, syphilis. Next, patient may also complain of or come with the history of generalized body changes, loss of appetite, loss of weight, swelling in the neck, either the laryngeal swelling or the nodal swelling, history of other occupational exposures like to asbestos, dust, unoccupations of being a singer or a teacher, family history, heredity causes or heredity addictions, history of previous surgery, therapy, or any voice procedures done on the patient, and any other feature the patient wants to mention. So, in short, you can present a case like a 57-year-old male patient comes with chief complaints of change in voice, change in speech. The voice is hoarse, intermittently, not throughout the day, associated with sensation of something stuck in throat, feeling of dyspnea. Patient is able to say 2 to 3 sentences at a time. There is no associated cough or sputum. It is also associated with mild difficulty in swallowing. This difficulty is to solids rather than liquids. There is no pain during swallowing. There is no regurgitation, no associated neck swelling externally. The above history is also associated with loss of appetite, loss of weight. Patient doesn't know the exact weight loss but estimates it to be around 1 to 2 kg over a period of past 2 months. So in short, each and every point, change in voice, dyspnea, cough, dysphagia, odynophagia, foreign body sensation, clearing of throat, swelling in the neck, and etiology, including tobacco, alcohol, voice overuse, abuse, TB, syphilis. All these need to be taken into consideration at large. And I'm repeating these so that the student is sort of learning them right now. And each complaint mention all the details, starting with onset, duration, and progress. How each started, abrupt, sudden, or gradual, duration since how long, and the progress, how each complaint is progressing, and any other feature associated with any of these complaints. Plus, with each complaint, you should know the causes of each of the complaint and what can be done for each of the complaint, like causes of changes in voice, cause of dyspnea, cause of cough, cause of dysphagia, and so forth. So each complaint, ODP, cause, each complaint described in detail, ODP, cause, and the treatment for each complaint. That's how you do your history and you know you become thorough for the examination. So that's how I'm putting it across to you. Now details of each complaint is mainly its onset, duration, and progress relatively for larynx cases. So that's why I have not made a separate entity for each of them. But you could go through my book or any other book for that matter. But it is these are the main complaints and the onset, duration, progress in each, and the etiology, which is very important regarding uh, uh, carcinoma larynx. So once again, change in voice, dyspnea, cough, dysphagia, odynophagia, foreign body sensation or clearing of throat, swelling in the neck, etiology, which mainly includes tobacco, alcohol, voice overuse, abuse, TB, and syphilis. That's your CA larynx history. In your mind, it should just kind of come across when you should just be able to ask these one, two, three, four, five, 6 points, to the patient. Write it down in your, this all goes beforehand only that I mentioned that the rules remain the same. You need to write down on a sheet of paper, whatever is there for the exam, need to draw in your diagrams with proper labeling or all on one side and then present to the examiner in a loud clear voice. So that's your total history. In short, just this small workout is your total history for CL larynx. So now we move to with some causes which I mentioned here, like hoarseness, lesion, which is commonly asked, lesions of the vocal cord, vocal abuse, laryngeal inflammation, mobility causes, and malignancy. Dyspnea, also you should note all causes of obstructive pathology and causes of stridor, which are extralaryngeal, intralaryngeal, within the larynx, and so forth. The typical classification, you should know all that. Cough, dry productive blood stain, causes of all should be known apart from onset, duration, progress, color in the cough, any foul smell or not, all of that. Dysphagia, odynophagia, ODP, and to solids or liquids, any treatment taken, and the causes of each. Dysphagia, odynophagia, foreign body sensation in the throat, swellings in the neck, you should know the causes because the case may go from one point to anywhere actually and should be knowing complete neck for CL larynx, complete neck in toto, in and out. Each swelling, the cause of each, the treatment for each, how do you diagnose them, how do they, what all will you ask for each. Total no, and then just go to CL larynx. Okay. Etiology, alcohol, know everything about alcohol. That's why I like what, how much is needed to call it as an addiction, how much is needed to call, to say that this has affected the body, what are the main components, what are the bad components of alcohol which leads to damages in the body, to the larynx, carcinoma, as well as to the liver or so forth. Smoking, what are the components in the smoke, carbons, hydrocarbons, uh, and so forth. Vocal abuse, you should know that a little bit on vocal polyps, TB and syphilis. These points are very important. Differences, but you can jot them down whenever, between TB, syphilis, and CLRS. These are the very important clinical points which help determine the differences. Points in points in the history, so forth. Points in the history. These are not typical points, but yet I mentioned these on this slide particularly because patients may complain of these. These don't fall in the typical protocol of asking, but may complain of any of these also. But don't divert, stick to your protocol and find out everything about this, like loss of appetite, no since how long, whether can eat solids, liquids, why not eat, how much weight is lost because of loss of appetite likelihood, over how much period of time, and so forth. Asbestos exposure, occupational I mentioned, the lethal agent leads to carcinoma larynx, but not many cases are reported in the literature. I've tried to find out a lot about asbestos occupational cause for CA larynx, dust, and the occupation regarding teachers and singers and so forth. Okay, so that's how, in short, a gist of history. The main points and in short, the history wherein you need to know a lot of details. So now we go to examination. Examination always again divide general and local. Local again would be inspection and palpation. Inspection again would be external, just from the outside, and inspection again from the inside, which includes the oral cavity, oropharynx, and larynx, and palpation. Okay, and then how you present your diagnosis. So here now, first examination general, poorly built, nourished, orientation in time, space, and person. Now these are far too beyond thinking points, but sometimes you won't get such cases. But if the patient has metastasis elsewhere, usually the lung, liver, and bone are the common sites of metastasis, but just in case brain or something will be a little bit disoriented and will because of encephalopathy kind of picture or hepatic encephalopathy kind of picture, will be a little bit disoriented, may not be able to answer so well. But then too, you won't get such cases, but just as a knowledge base, poorly built, nourished, orientation in time, space, and person. Cachexia may be there. How to find out a how? Cachexia is significant lean body mass loss plus fat loss. Clubbing may be there in these patients at times. Confirm that first. How do I identify? And the grades. Know the 4 grades of clubbing. See the fingers properly. Identify the grade of clubbing and mention just in case. Cyanosis may be there. Same late cases you may come across if the lungs have been affected. You won't get such cases, but just in case, you should know the causes of cyanosis. Jugular venous pressure needs to be ascertained. Lymphadenopathy needs to be ascertained, whether general and the neck nodes, generalized or neck nodes need to be ascertained. Now, if neck nodes are present, you can either present them here itself or you can give it across as a separate section of loco regional examination. So neck nodes, I've mentioned it here. If neck nodes are positive, describe it as a swelling now only or independent later on in relation. So if you describe it now, the next slides will tell you some things about the neck nodes. You can describe it now, describe as a swelling. Swelling, you know how to describe: site, size, shape, adherence to surrounding structures, any pulsation seen or not on inspection, any discoloration, color change seen or not on inspection. On palpation, the first thing is the firmness of the swelling, any induration there or not, any adherence to the skin, puckering there or not, any sinuses or fistula over the swelling there or not, any movement, whether it's you're able to move or not, any pulsation there or not over the swelling, if at all the swelling has any pulsation, whether it's expansile or transmissible pulsations. So that's about the general examination. These points may be there in these patients. So I have mentioned these points. You have to follow the complete general examination protocol, which I will just mention in a second. The complete general examination protocol is: one, conscious, cooperative, well-oriented in time, space, or person or not. Second, general condition, built and nourishment, afebrile or not. Third, pallor. Fourth, edema. Fifth, cyanosis. Sixth, clubbing. Seventh, jugular venous pressure. Eighth, lymphadenopathy, cervical, axillary, inguinal, generalized or local. Then the respiratory system, air entry, bilaterally equal or not, rales, bronchi, foreign sounds. Central nervous system, conscious, oriented in time, space, or person. Cranial nerves 1 to 12. Muscle power, reflexes. Cardiovascular system, heart sounds, first and second. Apex beat. Gastrointestinal system, hepatosplenomegaly, ascites. And this is about the general examination, total points. Of these are the ones which are likely to be present or have some relation more with a case of carcinoma larynx. So I mentioned these: poorly built, nourished, orientation in time, space, person, pallor. Sorry, I forgot to mention that pallor, which is very common in carcinoma cases. Cachexia, clubbing, cyanosis, JVP, lymphadenopathy, neck nodes, and if the patient is operated upon, then scars, sinuses, voice prosthesis surgery, any marks or lesions of that, then you have to mention that. Okay, so now if the neck nodes are present, I'm describing a bit of the neck nodes as of now straight away. Knowing that this is a CA larynx case, you need to know neck nodes, which laryngeal cancer transmits to which neck nodes per se. In neck nodes, first, if it's a swelling, same describe as a swelling, side, size, shape, adherence, feel on palpation, firm or not, so forth. I mentioned to you already. As a level, describe level 2, 3, 4 for supraglottis, usually that's the affected one. Level 2, this level 2, 3, 4, 6 for glottic carcinomas. If at all they don't spread more because of lack of lymphatic permeation. And level 2, 3, 4 for transglottic enlarged movement. Describe the node completely in detail. Supraglottic, rich, clinically you need to know supraglottic, rich lymphatic network, also midline. So level 2, 3, 4, and bilateral spread is common. Glottic, rare if precarious lymphatics. Level 2, 3, 4, 6, yet sometimes. Subglottis, primary subglottic carcinoma, this important clinical point, may present for DNB, may present as paratracheal lymph node, level 6 lymph node at times. This is an important point. So if a swelling is seen externally on the neck, describe as a swelling, site, size, shape, movement on swallowing, deglutition, indrawn during inspiration or not, palpation from behind from both hands, firm, firm or hard on palpation, adherence to surrounding structures. So that's how you'll describe a swelling. Now, local examination, external, the points are first. This is regarding carcinoma larynx. But the points are first, you describe the laryngeal cartilages. Examination of larynx, first you describe the laryngeal cartilages. It is done with both hands standing behind the patient. First inspection, the laryngeal cartilages. The larynx is expected for any mass, fullness, fistula, and movements during deglutition and respiration. It gets indrawn during inspiration and laryngeal obstruction. Tracheal obstruction does not produce such changes, and laryngeal framework may get distorted in certain tumors or malignancy. First thing now you have to describe is the patient's head should be flexed slightly to relax the neck muscles, and the hyoid bone, the thyroid, and the cricoid cartilages are identified. The cartilages are palpated for thickening, 1, 2, tenderness, and 3, any broadening. So that first point is laryngeal cartilages. Second point is the thyroid gland. So the second point is a thyroid gland which lies over the thyroid cartilage from second to fourth cartilage. Second to fourth cartilage. It is examined for its consistency, swellings within, tumor or any pulsations. Its movement is examined at deglutition and protrusion of the tongue. The second point is the thyroid gland. First point is the laryngeal cartilages. Second point is the thyroid gland. And then is regarding the larynx, if fullness there or not. Okay. And then we go to laryngeal crepitus. The movement method of eliciting is to hold the larynx from the forefront and move it horizontally over the spine. It is a grating sensation which is produced when the larynx is moved laterally on the vertebral column. It is present normally and is absent in post-cricoid malignancy and retropharyngeal lesions as the larynx gets pushed forwards and movements over the vertebral column does not occur. Okay. So this is regarding laryngeal crepitus. Now local examination internal. That was local examination external. Points first, any neck nodes you've already described, or you can describe it later on. So first point is thyroid or hyoid and bone and laryngeal cartilages, thyroid and cartilages, hyoid bone, first point. Second point, the thyroid gland. And third point, the larynx. You have to mention if you see any larynx or any fullness in the laryngeal area or any growth coming out of the larynx, which you mentioned earlier already, how to describe any growth or a swelling, size, size, shape, margins, movement of swelling, deglutition, indrawn or not, and palpation from behind. So that's how you will mention regarding external examination of the neck, larynx, and crepitus. You can examine here and here itself, laryngeal crepitus. So these are the points for external examination. Now going to internal examination, oral cavity, teeth, tongue, buccal mucosa, look for halitosis, dental caries, stains, tobacco, smoke, gutka. Look for serrated edges from the teeth, gums, discoloration, line, tongue, any patches, leukoplakia, mucosa. Look for the buccal mucosa, leukoplakia, melanoplakia, teeth in biting marks, and so forth. If any of this is present, you will have to describe each one in detail, okay? Which is a long, short, very, very long presentation as such. So I have put across all the points as much as possible. Oropharynx, posterior pharynx, then you go from the oral cavity, go to oropharynx, posterior pharyngeal wall, oropharynx, posterior pharyngeal wall, tonsils and pillows. Look out for any secondary growths, infiltration, inflammation, feel the area by palpation and describe and comment all of it in total detail if there is any positive finding. Next, larynx, exact procedure of indirect laryngoscopy and willing to do it in front of the examiner without hesitation. So you have to do the exact procedure, describe it and willing to do it in front of the examiner without hesitation. I will mention it in the next slide. What structures are seen? What structures are seen now on ideal? Excuse me. And mobility of vocal cord and the Jackson sign. Excuse me, please. This is a phone call from the hospital. Is it okay, please? I can take it for a minute, please.
Yes, ma'am. Yes, ma'am. You can take
Yes,
it.
please. 1 minute, please.
Yes, ma'am.
Hello. Yes. हाँ हाँ लिखो सर हाँ हाँ बोलो अच्छा तुमको वीडियो कॉल करो 5 मिनट में तुमने करो खाना पर So what structure seen? And then supraglottis, glottis, any structure, any subglottis or the tracheal rings are seen on indirect laryngoscopy or not. So indirect laryngoscopy, the points are what structure seen, what structure seen now, color description, mobility of the vocal cords, and Jackson sign is what the student should know. Then supraglottis, glottis, and subglottis, and any tracheal rings seen or not. Usual growth is occupying supraglottis 3/4 on either side, invading medial margin. Vocal cords could not be seen because of the overhang. Patient having sounds on breathing like stridor may be tracheostomized already. I'm giving you an example. Glottis growth, then growth on the vocal cord, site anterior 2/3 or posterior 2/3, anterior 1/3 or posterior 2/3. Surface above, under, movement on E, crossing the midline or not, the margins, variegated appearance, slough on it or not. This is how you would describe a growth on glottis. And any fixation of the cord, invasion, the reasons are the invasion of the cricoarytenoid joint and the thyroarytenoid muscle. So, and if any subglottis is seen, same way described as anything, whatever seen in the subglottis, swelling, size, shape, extent, appearance, color, feel on touch, bleeding on touch or not. Glottis and subglottis part may be having a nodule, polyp, or growth like which may look like benign pathology. What is meant is a vocal polyp can also be malignant, a small wart-like growth, proved only on histopath or similar may be given as a case. So student can voice that this looks across like a polyp, but it can be a malignant case as well. Example, a 1 centimeter lesion is seen on the right vocal cord, anterior 2/3 at the margin, red in color, irregular margin, firm in consistency, no fluid or gel-like structure seen within. Surrounding vocal cord appears normal in appearance. On mobility, vocal cord appears mobile, undersurface does not appear to be involved. lymph node seen or not, or palpable laryngeal crepitus present, stage grade TNM classification CL larynx with vocal cord can confirm only on, always say please, can confirm only on histopathology, and why carcinoma can be the first question to any student. Take home in short would be history, change in voice, dyspnea, cough, dysphagia or rhinophagia, foreign body sensation, clearing of throat, swelling in neck, etiology, tobacco, alcohol, voice overuse, abuse, examination, inspection, larynx, external mass fullness, palpation, hyoid and cartilages, thyroid gland, laryngeal crepitus, systematic examination of neck nodes, indirect laryngoscopy, and the diagnosis. That's how you would put it across for CLRN. Supraglottis would be dysphagia, hoarseness, important points to remember. Dysphagia, hoarseness, rich lymphatic network, notes, and about the vocal cords. Glottis, change in voice, commonness, poor lymphatic network, includes the vocal cords. Subglottis dyspnea, primary subglottis carcinoma to level 6 below the vocal cords. American Cancer Society notes are for laryngeal carcinoma are very good for staging of laryngeal carcinoma as well as details of laryngeal carcinoma. And also, obviously, please read through my book or any other book for laryngeal carcinoma. Common questions which can be asked, which I have felt through on thinking are causes of CA larynx, spread routes, which are very important, very nicely given on each subpart of carcinoma, details of IDL, surgical anatomy of larynx, surgical treatment and procedures of CA larynx, tracheostomy, speaking valves and tubes, post-laryngectomy rehabilitation, artificial voice and processes. These all need to be known by the to the student and by the student. Make thorough that this is known for the history and examination case. Okay, sorry, but I take your leave for the moment. I may have hurried up a little bit towards the end, but I need to address an hospital issue, please.
Yes, ma'am. Yes, ma'am. We understand, ma'am.
I
Uh,
hope it was useful to the students,
yes, ma'am.
and
It was wonderful, ma'am.
I hope it is. They just make all of this very thorough. Some of it is some details are given, and rest they just make each point very thorough. In short, history points and
Yes, ma'am.
know them thorough, examination points and know them thoroughly.
Yes, ma'am.
So
Yes, ma'am.
yes. So
Thank you
thank
so
you,
much, ma'am,
thank you.
for
Yes, thank you
coming
so
on
much.
DNB Mentors. Uh, thank you so much, ma'am. I would like to summarize what ma'am told and what we think. That first of all the students should know that you will not get very sick patient for case presentation. So you will not get a patient who is in trolley and he is gasping. So you have to be very sure that the patient will not be very sick. He might be sick. Okay. Second is the pattern. Pattern is you will get 20 to 30 minutes for examination. Then you will get 20 to 40 minutes for writing your case and revising. And in the meantime, if you suspect that there is a language barrier, then you should always call any help which is near to you. Mainly, they will be residents or they will be nursing staffs. So please call them before the examination only. And then you will have 20 minutes to 30 minutes for the presentation. So initial 10 to 15 minutes will be given to you for the presentation. And then the next 10 minutes or 15 minutes will be the examiner, he will ask you the questions. So you have to you have to give the answers. Don't think that you have to give a precise diagnosis. Be sure that you just tell them what are your examination points, what are your positive findings, and what are your negative findings. Never miss the name, the family history, the drug history, systemic disease history, and you have to be very sure that if there is a patient of carcinoma, you have to palpate the neck nodes because this might be the major negative point for your examination part. You have to, for this particular patient, you have to know the theory of spread, the names of laryngectomy. They will not ask you in detail about laryngectomy, but you should know about post rehab procedures. So ma'am has already mentioned that you should know about those things. Remember to take BP, heart rate and pulse. That is very important. Don't miss out. Don't miss that. And second thing, my question is, I don't think that you can examine oral cavity or do laryngoscopy or do posterior rhinoscopy or do ideal in this COVID times. So that we have to clear that how should we examine the patient, and be sure that you ask the examiners for a PPE kit, for gloves, for your shield, face shield, and you should know every named sign for a particular case. So I think this can solve your problem. So we will have another case presentation session very soon.
Is this for Mr. Dr.
Uh, so next I would like to introduce Dr. Zakir Hussain sir. He did his MSc ENT and DOHNS from England. His area of expertise is endoscopic sinus surgeries, microlaryngeal surgeries, sleep and vertigo. So he has worked in Kuwait,
Hello?
in Kingdom of Saudi Arabia,
Hello?
and CMC Vellore. And
Uh,
he is currently working in Kim's Column. He has written many books, out of which uh, exactly 6 books he have written. So first book is Otorhinolaryngology for theory purpose. Then he has written Instruments in ENT, then Manual in Clinical ENT, Emergencies in Clinical ENT, Handbook of Common ENT Surgeries. And now he is coming up with a new book named Current ENT Diagnosis. So I would like to welcome Dr. Zakir Hussain sir to give us insights on how to attempt the instrument station and other implants like middle ear implants and other. So, sir, you can start the presentation, sir. Zakir Hussain, sir. Just give me a minute. Ha, yes, sir. Sir, you have to unmute yourself, sir. Sir, you have to unmute yourself.
Okay,
Yes, sir.
now,
Yes, sir. You can start, sir.
yeah. Good evening, everybody. So this session, next 30 minutes will be on instruments in ENT. The time given to me is just 30 minutes, which is very short. I'll try to go through the instruments as much as possible. And let us start with rhinology. Actually, I put all the instruments together, but most of the instruments, the common ones, I'll be just skipping through. Just for the completion sake, I put in all the instruments.
Sir, if you
Few
think
ones,
that a particular instrument is
the
important,
most probable
please
one which is
mention it.
kept for the exam.
Yes, sir.
Yeah,
Please.
I will go in detail.
Yes, sir.
To start with, pudicum nasal speculum. There's a diagnose. What are the indications like diagnostic or therapeutic? Then coming to St. Clair Thompson long blade nasal speculum, Ilian self-retaining nasal speculum, Freyer's elevator. Here you should know it is used mainly to elevate the mucopericondyal flap and to lateralize the inferior turbinate, even to perform uncinectomy and to harvest temporalis tissue. And Howarth elevator, how it differs from the Freyer elevator is that in Howarth elevator, one end is blunt, the other end is sharp. The blunt end is mainly for the elevation of the mucopericondyal and mucoperiosteal flap. The sharp end is when you want to disarticulate from the lower end, where it is attached to the lower edge, where it leads a sharp dissection. This is Killian's bayonet-shaped nasal gouge, reduction of the spur. This is knife. The word swell means anything which revolves around 2 bars. Actually, this knife has been used mainly for SMR. Now, for septoplasty, if you want to remove the inferior strip, that can be done with this. Now, suction elevator. This is very handy instrument in the sense we can elevate the flap at the same time the vision also will be very clear. Coming to him and turbinectomy system. As you all know, it's usually not done, though it's partial or complete. It's no longer done. So we have so many procedures for terminoplasty. So this instrument now it's mainly used to cut the cartilage during septoplasty. Coming to Samberger's side biting anterior punch. This is a through cut instrument. It removes bone and soft tissue from the lateral wall of the nose, and it can be used even for widening of the maxillary sinus osseous. Even the uncinate remnant, if it is left behind, even that. This is Jensen's militant septum force. used mainly for removal of the cartilaginous and bony septum during ectopic. This is cartilage crusher used to morcelize harvested cartilage pieces for septoplasty and rhinoplasty. These are the steps of septoplasty, which I will not be going in detail. We'll go only through the instrument. This is the Welsham forceps and hash forceps. Welsham forceps, you'll find as in the screen, you'll find a rubber in one end, and that is mainly for reduction of the nasal bone fracture, to realign nasal bone fracture. The hash forceps, which is little stout and will bend, and the gap between two blades, which is for straightening and alignment of the nasal septum. This is the Rose eustachian tube catheter. This is no longer used as eustachian tube catheterization. It is mainly used for removal of foreign body from the mouth. And you have the ring at one end of the tip of the instrument. Coming to rigid nasal endoscope. It's about 18 centimeters long, and we have adult and pediatric and different angles also, as shown in the figure. We have 0 degrees, 30 degrees, 45, 70, and 120. Rigid nasal endoscopy has revolutionized rhinology and the surgical part too. So you have adult and pediatric. Adult it is 4 millimeter and pediatric 7 and 2.1 both. Now, here I would like to say that we have a new endoscope which is called endochameleon. Like how I have mentioned before, that for each angle, you need to have 0 degree, separate one for 30, separate one for 45, 70, and 120. This chameleon nasal telescope, in a single endoscope, you can get angles starting from 15 to 90. So as you see in the third diagram, side photograph, it's starting from 15 to 90, you get all different angles in a single endoscope. You don't have to change them. This is the latest one. This picture shows nasal endoscopy and nasal video endoscopy too. Bear in mind that each endoscope, whether it is 0, 30, 45, and 70. Yes, Doctor.
Sir, your voice is a little bit husky, sir. Can you please come closer to the mic? And can you please repeat this endochameleon nasal telescope, sir?
Sure.
Please, sir.
See, endoscope, rigid endoscope, we get in different angles, starting from 0 degree, 30, 45, 70, and 120. So you have to change the scope. Suppose you need to have different angulation, you need to change the scope. We have a new one, which is endochameleon nasal endoscope, where you don't have to change the endoscope. The single endoscope itself, you get all different angles, starting from 15 to 90. As you see in the third photograph, you have different arrows, and it shows that 15 degrees to 90 degrees. In a single endoscope itself, without changing the telescope or endoscope, you can get all different angles. That is about chameleon nasal endoscopy. And you should bear in mind that each endoscope, the older version, it has got a color. 0 degree is green. There's a color code given at the handle. 0 degree is green, 30 degrees is red, 45 is black, and 70 degrees is yellow. And even there are so many different techniques of holding the endoscope: side grip, base grip, reverse claw grip, pistol grip. I am not going into it. Now coming to the test instrument. So just name a few, then we'll come back to it. Scalpel, Beckesley wheel forceps, where to remove the polyp, and ethmoidal label. And regarding this instrument, there's always the space between the blade is limited. We cannot open it like near the instrument. And if you can notice, there is an eye noted at the upper jaw to visualize the tissue too. This gives the difference between the Beckesley forceps and the Takahashi forceps. Now, coming to rhinophore forceps, here there's a true cut. It cuts cleanly through the tissue and avoids tearing of the tissue. This is antral punch forceps, where with this we can do tonsillectomy as well as widening of the maxillary sinus OSCE. In this, the new and a recent advancement is the rotating backbiter is available. That is, you don't have to use one for the left and one for the right, one for the upper one for the lower one. So you have a rotating backbiter too. Now coming to the nasal sphincter, maxillary sinus ostium ceca, antrum grasping forceps. It comes with a name by Hoacer's antrum grasping forceps. This is mainly used for removal of the cyst or polyp or any tissue which is left behind in the maxillary sinus. And even it can be used for removal of the ethmoidal air cells. Hoacer's antrum grasping forceps. This is a cup curette to curate all the ethmoid air cells. And this is giraffe forceps, Kornbolger giraffe forceps. It's available in 45 degrees and 90 degrees. The jaw opening can be from side to side or from front to back. It's made mainly to assess the frontal rectus. Samberger mushroom punch. This one is mainly used for widening the sphenoid ostium. About the instrument, if you can see the tip, it's blunt. It is shaped like a mushroom too. Actually, the cutting edge is here, like how I am showing with the mark. So this is mainly used for the sphenoid ostium. This one also, it comes in straight as well as in angled. Straight one is used for sphenoid and angled one can be used for frontal rectus. Next, coming to the debrider handpiece and the console. You see the handpiece, the parts are, you have a cannula, which is an inner cannula, outer cannula, and the inner cannula, then the irrigation part and the suction. What you see in the picture, see on the right side is the console. And the cannula, you have, it comes in different angulations, starting from 40, 60, 120. So is 120, again you have, even in 60, you have two types. One is forward facing, one is reverse. Reverse facing is mainly for doing adenoidotomy or any nasopharyngeal mask. As far as the blades are concerned, you can say the blades can be divided as per the edges. It can be divided as smooth edges or serrated edges. Serrated edges can be again subdivided as single serrated or double serrated, which means that I'm talking about the inner cannula, not the outer. Single serrated and double serrated. The inner, both are serrated. Depending upon the type of edges of the serrated, again it can be subclassified as sharp blade and tri-cut blade. It comes in different sizes. Sharp blade is 3.5 and it comes in 4. And tri-cut, it comes in 2.9, 3.5, and 4. So the mechanism of action, the cutting mode can be oscillation, dabbing, or rotation. These are types. So these are the steps of the test which I will not do. Next, coming to the instruments for rhinoplasty. The first one is Cottel's columnar clamp. Second one is Kilner's ALR retractor. So Kilner's ALR retractor to visualize the vestibular area. As you know, you have a columnar incision and the marginal incision. Marginal incision has got the medial limb and a lateral limb. For the incision of the lateral limb, we can make an examination. We can make use of this Kilner's ALR retractor. Next is Optics nasal retractor for exposing the nasal dose. This is Joseph elevator, periosteal elevator. We'll use the periosteum over the nasal booms. This is chisel straight for reduction of the nasal hump. Nasal hump can be bony. It will be both cartilaginous and bony. So I'll show you a picture for that separately how it is removed. Nasal rasp. It comes in 10 different sizes, starting from 1 to 10. And this rasping edge is made up of tungsten carbide, like how the burr is made, same material. Now coming to osteotomy, you have both sides, left and the right one, and this edge which you see, which is blunt, so that it can avoid trauma to the lateral edge, and the cutting edges are the inner one. So these are the steps, like inverted gull wing, mid columnar incision. This is a marginal incision which I was talking about, medial limb. Then you have the lateral limb, complete exposure of the nasal dorsum. Here you have the chisel for removing the hump, and you have the off-ridge retractor too. There is a position of the for the lateral Once the bony upper part has been done, we come to the tip where we have intradermal and interdermal sutures, and finally the closure. There's a few words about these three, like merocell, surgicell, and isopore. Merocell is made up of polyvinyl alcohol in the compressed form, which we are using for every case of pest. I repeat, merocell is made up of polyvinyl alcohol in compressed form. Surgicell, it is an oxidized regenerated cellulose. It has got three actions. Adheres to bleeding surface. Second, it has got a vasoconstrictive effect due to the low pH of the product. Third one, it is antibacterial effective. That is anti-staphylococcus, anti-streptococcus, in fact, anti-pseudomonas. Nasopore, this is synthetic polyurethane form, which is biodegradable. Now, for epistaxis, we have 4 different techniques of management. Either it can be electrocautery or chemical cautery, thermal cautery, or it can be cryo, which you see is for electrocautery. The second one is chemical cautery, which contains silver nitrate. So I hope how it works. Silver nitrate produces, it combines with moisture or saline, or mainly moisture in the nasal cavity, and produces nitric acid, which cauterizes the area. Now that's about the rhinology part. Coming to the otology part, the first one is endo-oral speculum. So as you all know, now we are in the generation where we are doing endoscopic surgery. So I don't think that all this endo-oral speculum will be kept for the exam, even then, just for the completion. So you should know the indications and type of incision, like William Wild's incision, modified William Wild's incision, Tierman's incision, Lempard's 1, 2, 3, 4 big types of incision, Impson's oral syringe, Jobson-Horn's probe and ring curette, Gardner-Brown's tuning fork, and different mechanisms Hertz has been used, and what are the different techniques for Rennie's test and mechanism of Weber's test, and Aron theory, dispersion theory. These are the basics. Coming to the Meininger toe for making an incision in the tympanic membrane. So mainly we have 3 different types of grommets which will be kept. One is Shah grommet, other one is Shepherd, other is Armstrong. In Shah, if you can see, we have an inner flange and an outer flange. And you can see that whenever there's a shoe horn, it has got 2 actions. There is easy insertion and late extrusion. The other side, what you see is the outer flange. Indications of grommet you should be knowing. And there are so many different types of grommets. So many, I can name at least 50 to 70. The most common ones are Shah, Shepherd, and Armstrong. So these are the few ones which I have just kept it.
Sir, can you go a little bit slow, sir? Because the instruments are very interesting, sir.
Yes.
Little bit.
You want me to go slow or fast?
Yes, sir. Yes, a little bit slow, sir.
Oh, so this is a T-tube introducer, and here you have T-tube. It can be fashioned, and it has to be introduced inside the introducer, like how it's shown in the picture. And we should know the different indications for T-tube. These are the common questions. If during surgery grommet falls into the middle ear, what has to be done? What are the indications for mini Shah grommet? What are the indications for T-tube? How do you treat recurrent otorrheic patients with grommet in place? And very rarely, what is Bjerkan principle in grommet infection? So this is about pictures on laryngectomy, incision, aspiration, grommet incision, insertion, and grommet imposition. Now, next one, Mollison's hemostatic mastoid retractor, Farabiu's periosteal elevator, Lempard mastoid scoop, burr, and burr, a material which is made up of its tungsten carbide or titanium. The diameter of the cutting burr usually starts from 0.5 to 7 millimeters, and the length it varies from 45 to 70 millimeters. So as far as the diamond burr is concerned, you have two types. It is either irregular surface for cutting or regular rough surface for polish. This is house microtube, right? This is Rosen's knife, blister flag knife, and have bills. Rosen's knife and blister knife both are used for incision in the external artery canal for elevation of the flap. And Bill's knife, which is blunt type, as you see, for placement of the graft. Then you have angle pick and straight pick, right? And crocodile forceps and cup forceps. This is sclerotomy scissors, piston clipper, twin bar. Now coming to auto telescopes. Usual length is 10 centimeter with a diameter in three different range, starting from 1.9 to 2.7 and 4 millimeter. And we get in four different angles: 0 degree, 30, 45, and 70. Indications, as I know, it has to be diagnostic and surgery. This is Spencer's nystagmus spectacle, which comes in 20-degree convex lens. It prevents visual fixation so that nystagmus can be seen. It can be enhanced and seen properly. Magnified view. Coming to the hearing aid, we can have a picture or a model, and they may ask you, please mark where is the microphone. So at this point, you should know the types of hearing aid. Mark the microphone area. What do you mean by cross hearing aid? What is the function of vent? What does one mean by inadequate benefit from a hearing aid? Now, bone anchored hearing aid. So this has got three parts: the implant, the abutment, and external sound process. So you'll be asked to identify mechanism of action, what are the advantages, disadvantages, and what is the timing of surgery, and what is the complications. What are the complications? And the last one I have put in, what I have added up is, in case MR has to be done, what has to be done? See, the external sound processor, it contains a ferrous part, and titanium is very compatible with MRI. So suppose in case the patient with a bone anchored hearing aid is undergoing an MRI procedure, only the external sound processor has to be removed. So these are the steps of surgery for Baha. So first, the implant has to be fixed. Next, the abutment. So this is the implant, and this is the abutment. Next, you have partially implantable hearing device and fully implantable hearing device. In partially implantable hearing device, you have vibrating ossicular processes, and one which is fixed to the incus is a floating mass transducer. So as far as these two sessions are concerned, either the bone anchored hearing aid, this one can be kept, or it will be the vibrating ossicular process which can be kept. So the latest one is a auditory brainstem implant. We don't have a picture for that. So at least you should know 3 or 4 indications. The common ones are the contraindications, just think the other way around. The contraindications for cochlear implant will be the indications for brainstem implant. Like the common indications are cochlear nerve aplasia, traumatic cochlear nerve avulsion, failed cochlear implantation, ossiculation of the cochlea, and it goes on. At least 3 or 4 you should know. Now coming to TORP and PORP. So total ocular processes, both has got 2 parts. One is the head and the shaft, and it is made up of Teflon. So TORP, if you see, the shaft is thin, and for PORP it will be thick. As far as the TORP is concerned, the shaft to be placed on the foot plate of the stapes, and PORP it should be placed on the head of the stapes. So processes can be made up of natural material, which can be cartilage or bone, or it can be hydroxyapatite, or platinum, steel, fluoroplastic or Teflon, and gold. Each one has got its own advantages. Now coming to oropharynx. This is Boyle Davis mouth gag. We have so many different types of mouth gag. This is Boyle Davis. Then you have Jennings, Keller, and we should know the indications and complications for that. This is Jennings mouth gag. This is mainly used in edentulous patients. Blade rest on the alveolar margin. This is Dingman's mouth gag. This is mainly used in cleft palate repair, palatoplasty, and pharyngoplasty. The advantage is that it has got a tongue depressor, and along with the cheek retractor, it has got small wire springs which can fix the palatal flap. Next is French bipod stand, which fixes the Boyle Davis mouth gag. McGuire and tonsillar bridge or plate, which stabilizes the French bipod staff. Was long dissecting forces. White Evans tonsillar dissector. East tonsillar snare. Mollison's blunt tonsillar dissector, the anterior pillar retractor. Jonko's suction tube. And Burkett's long slender tonsillar hemostatic forceps. Neger's tonsil artery forceps and the holding forceps. These are steps for tonsil. Not going through, but here we see the fifth diagram onwards. Incision with the forceps, was forceps. Second one is a blade. Third one is a scissor. Fourth one is a unipolar diathermy. Fifth one is incision is made or the surgery is done with the help of harmonic scalpel. And even the latest one is the coblation. So if you see, all these instruments have been going a little fast because I want to concentrate mainly on the coblation, which is the one which is used. Now, the different techniques are, you have coblation wand, diathermy, bipolar diathermy, harmonic scalpel, the old one, the new one. So, you should know the difference between coblation and the general unipolar diathermy. Coblation, here you pass the electric current through saline. It creates a plasma layer. When current goes through normal saline, you get ionized sodium ions at 40 to 70 degrees Celsius. This ionized sodium ion, the molecular bond, cellular bonds, that's how it works. And it is bipolar. And the thermal damage is very less. The area is just 1 millimeter. When you compare with electrocautery, it's about 3 to 5 millimeters. And if you can see that the temperature difference in coblation is just 40 to 70 degrees. When you compare with unipolar, it is 300 to average of 400 degrees Celsius. So the damage is more. And of course, the postoperative pain is more. So coblation, the word coblation co stands for controlled ablation, stands for MELT. So to repeat, it utilizes a system of radio frequency, bipolar electrical current, the current that passes through a medium of normal saline, which results in the production of a field of sodium ions. These energized sodium ions are capable of breaking down intercellular bonds and vaporizes tissue at a temperature of just 60 degrees Celsius. Now, coming to the new advancement, what we are using now is cobblator 2. The latest one is Werewolf. It's called as Werewolf. The cobblator, if you see, you have a system with a separate saline module, and that saline module, it works on the gravity-dependent saline delivery system. And if you see the equipment, it comes in neurological numbers like coblation. You have cobblator as well as the coagulator, in which you have numbers starting from 3. But the Werewolf system is all in one system, and it works. And the saline, it works as a pump delivered saline, and you have only 3 markings in that, which is low, medium, and high. This is the latest one. And the Werewolf system, even the cobblator wand is different. In the sense, the same wand can be used for tonsillectomy and adenoidectomy. You don't have to change it. You see the comparison here. You see the difference. This is not reinforced. This halo wand, it is reinforced. This is a new advancement when as far as the coagulation system is concerned. Now coming to adenoidectomy instrument, St. Clair Thompson's adenoid curette with cage, without cage, and this is the steps for surgery. Coming to the sixth slide, you can see the curette, it goes sideways, then you turn it to 90 degrees, hold it like a dagger, and slight flexion of the neck, remove the whole adenoid. This is suction cautery. This is Pellinius peritonsillar drainage. This is for drainage for twins. Tongue tie guide, nicknamed as Mickey Mouse forceps. This is for the release of tongue tie. Laryngeal treatment, direct laryngoscope, type, indication, technique, and complications should be known. And these are the steps for laryngoscopy: the position, mouth guard, how it is introduced, visualization of uvula, epiglottis, and examination of the larynx. Anterior commissure laryngoscope, it gives advantage of better examination of the anterior commissure, posterior commissure, as well as the subglottis. This is laryngoscopy with chest stand and MLS in progress. Flexible fibro, and what you see, the picture you see on the right side is a portable one. The field of view is 85 degrees. Range of the tip is 130 degrees up and down. Outer diameter is 5 millimeter, and total length comes to about 585, and working length comes about 360. Here, I could take a few minutes. Like, we should know the steps. Like, first you have to inquire if the patient has already undergone this scope procedure or it is his first experience. Explain the whole procedure to the patient, and need to avoid, and you have to tell the patient he has to avoid food intake for next 20 to 30 minutes. Sanitize, wear gloves, examine the endoscope properly. Anesthetize the nasal cavity, lubricate the endoscope, apply anti-fog. Introduce the endoscope through the patent nasal cavity. At this point, when you introduce through the nasal cavity, the patient is advised to breathe through the mouth. Once the pharynx, advise the patient to breathe through the nose at this point, negotiate into the oropharynx. When it is in the oropharynx, ask the patient to protrude the tongue, and it gives better examination of the valvula. Next, ask him to say the word E repeatedly to note the mobility of the vocal cord. And next, ask him to breathe in and breathe out so that if there is any vocal cord polyp, it can be seen. If you want to examine the pyriform fossa, it can be done in two different. You ask the patient to do a valsalva manner, or ask him to turn the head to the left or right to see the corresponding pyriform fossa which opens. From this step onwards, if suppose a swallowing study has to be done, then we can proceed with the swallowing study. In case the flexible scopy is being done to rule out sleep apnea, two things have to be done. We have to do Muller's maneuver, which is nothing but reverse valsalva maneuver, and we had to do a word scoring. Second one, the new one is end expiratory retroglossal area. Coming to the next instrument. This is oropharyngeal laryngeal foreign body removal force. Next, going for tracheostomy. This is a part of the tracheostomy tube. You can see all the points are given, some numbering have given. This end is the balloon valve for the pilot balloon. Then you have the inflation line. Then you have the connector, flange, outer cannula. 7 is the cuff, cannula, and the operator. You should know the types of tube, material, what it is made up of, indications, a few indications of tracheostomy, few complications of tracheostomy, and what are the different layers starting from the skin till you reach the trachea. These are different types of tubes. Like so many different types of tubes. Cortex tube, Fuller's tube, Jackson tube, Shelley tube, so many are there. This is the new one, LAN system. It's in the cuff. Each time when you inflate air into it, you are supposed to use As I show in this, you are supposed to use a cuff manometer and keep the pressure between 50 and 20, 15 and 25 centimeters of water. What happens is if it is over injected in land system, which is a new one, if by any reason the intratracheal pressure increases, the extra pressure it goes into this system. So that pressure is not transmitted to the. Then you have the uncuffed tube. Uncuffed tube, you should know the indications of uncuffed tube. As you know, it's mainly used in children for radiotherapy and for speech also. Advantages, contraindications. What are the normal use of cuff? It stabilizes the tube. It prevents aspiration. If you want to give a positive pressure ventilation, you need a cuff. And what are the disadvantages of the same? The disadvantages of cuff, like tracheal ulceration, swallowing is impaired. So if the tube is blocked in the presence of cuff, patient can get respiratory. Next is adjustable flange. This is mainly indicated when the cutaneous tracheal length is more, like in short neck patients, outpatient short neck patients. So you should know the indications and limitations for it. This is a speaking valve. This is a one-way valve. The patient doesn't have to occlude with his finger. And next is occlusion care for decannulation. Then there's cuff manometer. Then you have two types of tracheal dilator. There is Proceus dilator, Lamport's dilator. This is for insertion of the tube. Change the tube also it can be used. You had a humidifier, it's called a Swedish nose or HME humidifier, heat and moisture exchanger. What it does is it collects the patient's expired heat and moisture and returns it during insertion. Coming to the bronchoscope. So the parts of bronchoscopes are, it has got a shaft, got a handle. This part, the suction is connected to this part, and we have ventilation, the telescope connection. The difference between the bronchoscope and the esophagus is that bronchoscope has side vent. Usual length of bronchoscope is from 40 to 45 centimeters with side vent. You should know the indications of bronchoscope, diagnostic and therapeutic indications, and the complex. Adult scope and pediatric scope. It comes in numbers like 6 adult 6.5, 10.5, and 8.5. And for pediatric, it starts from 2.5 up to 4.5. And when you use endoscope, now we have the telescope used for bronchoscopy. These telescopes are, which is 4 millimeter in adult and 30 centimeters in length. These are the depths of bronchoscope, which I'm not going into detail. Now coming to esophagus. Esophagus scope, normal length is 40 to 45 centimeters long, 16 to 20 centimeters diameter. You should know the indication, diagnostic and therapeutic. The parts are handle, shaft, IP, light carrier, and the distal lobe. And you should know the complications too. You have Jackson scope and Negus esophagus scope. So Jackson scope illumination is distal. It is a single bulb one illumination source, and diameter is constant. Whereas in Negus, the diameter keeps on tapering distally. It has got a double source of illumination. And in Negus, you have markings present on the endoscope. Now coming to laryngoscopes, you have Macintosh, Magel, McCoy's laryngoscope. You should know that identification and complication for the same. Uterus oropharyngeal airway, nasopharyngeal airway, indications and complications. So indications for these are make the airway patent, insertion of the suction catheter, and better mask fit tube. This is brain mask because it has been designed by a surgeon called Mr. Brain. This is laryngeal mask airway. The main indication for that is where facial mask is difficult to use, or in case of failed intubation, or you want to stop intubation like MRI. Complications are high chance of aspiration and airway trauma too. The main advantages are it's very easy to insert, but possible to insert in any head position too. Endotracheal tubes. The usual material it is made up of is polyvinyl chloride, silicon, and latex. Ideal radial of curvature is 12 to 16. One end is bevel, with the Murphy's eye just opposite to the bevel end. There is a radio opaque marker line too. This is our Elvin tube. The curve allows the breathing system connected to be placed away from the surgical. So it's mainly used in head and neck surgery. Main disadvantages is very difficult to do a suctioning. This is flexometallic tube. As you see in this picture, second picture, there's a metal spiral wound reinforcement around it. This is used only in those situations where there is high possibility of the tube being kinked. So the main disadvantages will be in this tube will be nasal intubation is difficult and the tube cannot be cut or shortened. Laser flex tracheal tube. There are two tubes in this, cup in this. This cup is filled with saline and not with air. That's
Sir, we are
hello.
not able to. Okay.
Yeah.
Thank you so much, sir. It was really very interesting, sir. Even I have never heard about endocamelian nasal telescope and this wave wool system. So thank you so much for your precious time, sir. I think we all
Hopefully I
have
have
to.
covered all the instruments.
Yes, sir. Yes, sir. You have covered all the instruments, sir. And thank you for giving us your precious time, sir, from your busy schedule.
Well,
Uh, yes, sir.
well,
So I think we all have to see. We have to repeat your presentation again and again on the YouTube or by the video, so that we can understand each and everything. Uh, so I would like, sir. There are few questions, sir. Can you please repeat the grommet part, sir?
yeah, sure. You want me
Yes,
to
sir.
go back to that?
Yes, sir.
Yeah,
Grommet.
you can ask me other question.
Yes, sir. And sir, what was the composition of nasopore?
Come again. Polyurethane form. It's a polyurethane, biodegradable polyurethane form. Nasop. This is biodegradable urethane form. See, this is nasopore. This is a polyurethane form, which is usually kept post-fest where you don't have to remove it. Merocell, actually, when you place it, we take it off the next day. And Merocell is mainly used only for mild bleeding, and it has to be removed the next day. Merocell is made up of polyvinyl alcohol in a compressed form, and you have to inject saline. But Tennisopor, you don't have to inject anything. You can fashion it up. You can place post-fest where you don't have to remove it. It is synthetic polyurethane form. It is biodegradable. So coming to the grommet. So this is the grommet. This is a Shah grommet where I have outer flange and the inner flange. The inner flange is the shoe horn. In any grommet, whenever you have a shoe horn, it has got two purposes. One is easy insertion and late extrusion. These are the two functions of shoe horn. So then this is the outer flange. The one you see after the procedure. And these are the pictures of so many other types of grommets. And if you see the Armstrong, one side is angled. This is because this gives the same angulation to the tympanic membrane, so the easy of insertion. But bear in mind, this is the long acting, which is kept for more than 1 year, permanent use. And chances of perforation is very high. So this is the material, how it is made up of, what it is made of. Fluoroplastic, vinyl, polyethylene, elastic, titanium, even gold. This is the T-tube introducer. Actually, you have so much prosthetic. Just for that, we need a class for it. Dr. Pratik, are you there? Can you hear me? Dr. Pratik? Hello, Dr. Pratik, can you hear me? Hello, Dr. Pratik.
Hello, sir. I'm Dr. Bhargav, sir, conducting this.
Yes, can you hear me?
Dr. Pradeep, yeah. He has some issues with this computer. So,
Okay.
sir, sir, you can continue, sir, or you want to take the questions or something, sir, till the Pratik comes. Hello.
Hello.
Hello. Hello. Yeah. Zakir Hussain sir is online.
Yes, sir.
But
Hello, Zakir sir. Hello. Hello, Zakir sir. So my laptop was stuck in between, so I have to join again. I'm so sorry. Zakir sir. So few points for students. You have to remember every basic instrument because they will carry negative marks. And you have to remember all the numbers, all the colors, all the length, and all the material. So remember it again, numbers, color, length, and material. Uh, and it is very important. If you are not uh, clear with the basic instruments, I think you will land up with negative marking. So, Zakir sir. Zakir sir. I think he has left. I will call him. Just give me 1 minute, sir.
Can you hear me? Yeah. Very good. I can hear you. I'm saying hello.
Hello. Hello, Zakir sir. Hello, Zakir sir.
Yes, sir. Can you hear me?
Yes, sir. Yes, sir. Now I can hear you.
Hello.
I'm so sorry for the inconvenience, sir.
Yeah.
Yes, sir.
No. I was repeatedly saying hello, but I think you were not able to hear me.
Yes, sir. Yes, sir. Sir, thank you.
Go ahead. Go ahead.
Yes, sir.
Hello. Hello.
Where we can find your instruments book, sir? Is it
Yes.
on Amazon?
It's break. I cannot hear what you said. Told I couldn't hear anything.
Hello.
You asked me something about the book, Dr. Pratik.
Hello.
Yeah. Can you repeat? You asked the book. You mean the instrument book?
Hello.
Dr. Pratik, can you hear me? Hello, Dr. Pratik.
Hello.
Yeah, yes, Dr. Pratik, I am with you. Can you hear me? Dr. Pratik? Hello. 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 Dr. Pratik, can you hear me?
Hello, sir.
Hello. Yeah, can you hear me? I
Yes, sir.
think the signal is weak.
Yes, sir. Its signal is very weak, sir, and I was muted, sir. That's why, sir. So thank you
Okay,
so
okay.
much, sir. I'm so sorry for the inconvenience at the end, sir. Please
No, no,
pardon.
that's fine. I'm comfortable.
Yes, sir. Thank you so much for giving us this opportunity, sir, to have you here. Thank you so much, sir.
Thank you, Dr. Pratik. Thank you, William.
Thank you so much, sir. Thank you, sir.
Okay.
And thank you, Sri Harsha ENT Foundation and DNB mentors. Next week on Thursday, we are doing a audiology session. So in that, we are actually going to ask the examiners how to do a better reporting, how to read a better report, how to do disability calculation, how to plot a PTA, how to do masking, and what are the recent advances in audiology. So thank you so much for coming and joining. We will meet next week on Thursday. Thank you so much, sir. And
Okay.
thank you,
Most
Dr. Srihasha. And thank you, Dr. Bhargava, for arranging all these things. And thank you, Dr. Neha ma'am and Dr. Zakir sir for coming, sir. Thank you so much, sir.
well, most.
So we will call it a day. We will meet next week. Thank you so much.